Today's episode is brought to you by Microsoft Dragon Copilot, your AI assistant for clinical workflow. Kristen, this thing's amazing.
It is.
It eases administrative burden.
Check.
All right, you want that. Definitely.
Mm-hmm.
Automatically documents care.
Check.
It streamlines workflow. We mentioned that.
Check.
And also just promotes a healthy patient-clinician relationship.
Check.
We need things that do that.
That's right.
Especially this day and age. We need more of that. Learn about how Dragon Copilot can transform the way you work. Visit aka.ms/knock-knock-hi. Again, that's aka.ms/knock-knock-hi.
Knock, knock, hi.
Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken. This is your one-stop shop, of course, for all ththings eyeball related. So a couple episodes ago, I did a topic of sympathetic ophthalmia, where I basically just was like, oh, I'm going to just choose things I've never seen before. The zebras of the most zebra of the zebras, things that you might never see in your career. And so I did sympathetic ophthalmia. So go listen to that. I think people really seem to enjoy that conversation. And so I'm going to do another one today. I'm going to talk a little bit about certain types of ischemic optic neuropathies, or just miscellaneous optic neuropathies, not even just ischemic. I'm going to talk about one ischemic one, but some other ones that are a little bit, these are disorders of the optic nerve that can be devastating to your vision. And so we'll get to that a little bit later. But first, so I am recording this the day after the infamous Tylenol-autism press conference featuring President Trump, RFK Jr., Marty Makary, Bhattacharya. So the whole team was there. The whole team was there, and it was pretty bad. It was, I've made a video. I think I've talked even recently on this podcast just about, because we knew this was coming, right? This was, about a month ago, I'd say, like it was like leaked that they were going to try to pin autism on Tylenol, on acetaminophen. And it's just, think about it let's take it first from a big picture. So people have been trying to figure this out for decades. And then you're telling me that RFK Jr., a guy with no public health background, no research background, can use the resources at his disposal to find the answer in about 6 months. So just your antenna should be up just based on that, okay? But let's talk through like what their evidence is for this, because like there have been a couple of observational studies of, I think one of them is maybe up to 1,000 kids that found an association between Tylenol use and autism. An association, no causation. Again, this is like the correlation is not causation type of thing. And so right there, you have to question the level of evidence on something like that. Observational studies, they're not placebo-controlled trials. They're not randomized controlled trials. They're not blinded. And so you kind of have to keep that in mind when you're evaluating this evidence. Lots of confounding can be present when you're talking about observational studies based on survey data. But also, that is not even the best quality study that's out there looking at this association between Tylenol and autism. Sweden, I talked about this recently. I swear I did. Maybe a couple episodes ago. Sweden put out a study just last year, 2.5 million kids, But they did a sibling controlled trial. So they tried to account for the role that genetics might play in this association. And once you did that, the connection between Tylenol and autism drops out. All right, they did not find it. That is a better study. So you think that would trump, no pun intended, uh, the data that they are using to base this accusation on. This is this saying that there's a causation between Tylenol and autism, but they're not even using the best data we have to make that claim. And this is dangerous. This is dangerous because you got misinformation is not new, right? We've been dealing with misinformation for decades in medicine. It's just gotten a lot worse, and now we're getting it from the highest levels of government. Look, I get it. If there is really, if acetaminophen really does like increase the risk of autism, lead to autism, cause autism, however you want to say it, well, okay, but let's see the data. Let's make sure the data backs that up before you go and start scaring people about this. And so you have Trump literally telling people, tough it out, telling pregnant patients, like, tough it out. Whatever you do, don't use Tylenol. The data we have does not support anybody making that claim, much less the president of the freaking United States of America, right? I mean, also, like, please, like, pay attention to your doctors, like, take your doctor's medical advice and not a politician's medical advice. That's another thing. But people are going to listen to this. People listen to it, and they're probably already at their doctors questioning it. You probably got, I'm sure you talk to any OBGYN, I'm sure they've already been getting calls about this. It just takes time to have to fight that misinformation because as we all know, misinformation travels so much faster, so much easier than factual information. It's going to take 20 times more effort to combat this. All right. Until we actually have evidence that shows what they wanted to show. We don't. We don't. That's another problem because that's not how medicine works. You don't have a conclusion, then you try to find studies to support that conclusion. You just do the science, you do the research. It's a mess, and that it wasn't even in. I one of my, I get we've been getting this from the president and RFK Jr., right? Making claims, lots of things that are not true or partially true or just taken out of context. Like they are politicians like that. So okay, I'll concede that. Like that, we just know that's part of the game with them. What my biggest complaint, one of them about this whole thing was the physicians that are up there. Marty Makary in particular, head of the FDA. This guy, this is a quote, a direct quote from Marty Makary, MD. There is a causal relationship between prenatal acetaminophen use and neurodevelopmental disorders of ADHD and autism spectrum disorder. A causal relationship. All right. There is nowhere in the evidence that we have that even comes close to suggesting there is a causal relationship. It's irresponsible to say that. And I just can't believe it's coming from like an accomplished physician. It makes me angry. It makes me sad. Because now we got to fight against this, right? Now we got to try to set the record straight with people on social media and in person with our patients, which we're going to do. We have to. And so those of you who are listening who are not in medicine, you might be thinking like, what's the big deal? Like Tylenol. I don't even take Tylenol. Like Tylenol barely works for me. I'd prefer other medications for pain and fever. So let me just tell you, like just medical, I know I'm an ophthalmologist, but like this is pretty basic stuff when it comes to, this is all stuff you learn in med school and pretty common. So, Tylenol is almost ubiquitous. It's just, it is what is so effective at reducing fever and treating like mild to moderate pain, that most patients in the hospital, they have like an as needed order in their on record while they're in the hospital that says, okay, if they have a fever or they're in pain, they can have a Tylenol. Nurse can just give Tylenol because it's safe as long as you use it in the recommended dosage. Yeah, it can cause liver failure, but only when you take it in extraordinary quantities that no healthcare professional would ever recommend, and something we all know not to do, right? Says it on the bottle. You don't take so many pills of this stuff in a 24-hour period. But that's true with any medication, right? Whether it's ibuprofen, even water. You can overdose on water. Like you can, anything you put in your body, you can take too much of it and it can kill you. So it, so every patient, has this order. And so now we have a situation where there's so much fear out there. It's been put out there now. It's done. All right. It's done. The president of the United States went on national television and talked about this. And so now there's going to be a lot of fear, people not wanting to take Tylenol. Well, what can happen when you take away the most commonly used medication to treat fevers? Well, you'll either get just untreated fever, and that can be a problem because hyperthermia, it can cause brain damage. It can send someone into seizures. It can, and that's even for adults, but especially for kids, febrile seizures. It's bad for the fetus if you're pregnant. It's bad. And so now you're taking away the one thing that we know like is safe and effective for people to take in recommended quantities. And so when I put out on Twitter, which I knew what I was getting into, like I know what the response is going to be. In fact, I immediately posted this and I turned off notifications for that post because it's like I'm not even going to read the comments. I already know what they say. I just said this will, in response to Donald Trump saying, "Don't whatever you do, don't take Tylenol." I said this was going to kill people because it probably will because this situation is going to happen. And I hope it made a lot of people angry. Some people agreed with me. A lot of people got angry. And when I say that, it's not hyperbole because either people are not going to treat the fever and that can lead to all those problems I just mentioned, or they're going to take alternatives. And the most common alternative that's readily available for people is NSAIDs, Motrin, ibuprofen, Advil. This um, this is also a fever reducer, also a pain medication, but it has significantly more potential side effects. Number one, it's not safe to use in pregnancy, right? Um, but also, long-term use, even at recommended doses, longer-term use, you take it for a couple weeks, then you can get gastric ulcers, you can get kidney injury. The risk profile is much higher for NSAIDs than it is for acetaminophen, again, at recommended doses. And so you can see a world where people, they have an option of, and often what we'll say to kids, and I heard this so many times from my kid's pediatrician, it's like alternate NSAID, alternate Motrin, alternate with Tylenol, because you don't want to give too much of one particular medication. Well, you're taking one of those away. What are parents going to do? What are just adults going to do? Right? And now they only have one readily available thing that can treat fever and pain over the counter, or they're going to turn to opioid pain medicine, basically just medicines that have a higher risk profile. And that's dangerous. We're going to see the effects of that. And one of those effects might be death. Not to sound dramatic, right? But come on. And for what? For what? Because there is a low quality study that showed it at a possible association. And we have a different study in Sweden of 2.5 million kids that is a better study that takes genetics into account that does not show that association. Certainly not enough to go in front of the American people and say, don't take Tylenol. Like you don't have the evidence to say that from that position of power. And it's horrible. And shame on Marty Makary, man. Like, you know better. You can't tell me. Like, these guys are smart, right? They know medicine. They know research. They know what they're doing. So this begs the question. Actually, let's take a break, and I'll come back, and I've got a few more things on this. Hey, Kristen.
Yeah.
I know that you love when I talk about the cute little mites.
Mm-hmm.
Yeah, but I thought we could take a break from that. Is that okay with you?
That's fine.
Yeah, because I'd like to focus on the eyelid symptoms and disease that an overgrowth of Demodex causes.
Okay, I like that idea. No mite talk.
So Demodex blepharitis, it often gets misdiagnosed or just missed entirely because a lot of symptoms overlap with other eye conditions.
Okay, so what are the top symptoms that people should look out for?
Usually itching along the eyelid margins, swelling, irritation, redness.
That sounds like it could be allergies or lots of other things, too.
It could be a lot of things, but exactly. And the key is if your doctor spots crusties on the margin of the eyelid.
Technical term.
Well, we call them collarettes, but crusties is a good term. That tells you it's Demodex blepharitis right there.
Well, I really like that there's a clear sign to know for sure.
And once you're diagnosed, there's a prescription eye drop treatment available for this disease.
Ooh, that is good to know.
To learn about the common symptoms of Demodex blepharitis and more, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. So the having Marty Makary get up there, MD, and say there is a causal relationship between acetaminophen use and neurodevelopmental disorders makes me wonder, and I keep asking myself this question: why are these physicians who are smart, they're brilliant people, they know better, Makary, Bhattacharya, Prasad, all these people, they know what they're saying is not true and it is just contributing to misinformation. Why are they doing it? Why? I think it's power. I think they get a taste for the access and influence that comes with being in Trump's inner circle. And it's intoxicating, right? They don't want to lose that. I don't know. This is a tough time in medicine, and I don't know. I'm going to talk to the. This is interesting. This weekend. By the time you hear this, I will have already given this talk. These episodes come about a week and a half after I record them, and I'm talking to the American Academy of Pediatrics. Talk about a group of people that are having a tough time right now. Man. I haven't given my slides to them yet just because I feel like I needed to wait till the last minute, because who knows? And good thing I did, because now I'm going to adjust what I say, maybe even make a skit specifically related to this topic. Actually, I already have done that. I talked about the Tylenol thing a couple weeks ago when I first heard about it. But people are having a tough time. Morale's just making it worse, right? It's like we're stuck talking about this, and when we got a whole healthcare system that we need to fix. It's like I haven't even been thinking about the fact that United Healthcare is still out there doing their shit, because we got to try to convince people Tylenol's safe. I would love to be putting that effort toward dismantling the prior authorization system, or trying to shine light on the unethical practices of health insurance companies. Only so many hours in the day, folks. Only so many hours in the day. All right, I'll let you know. I'll let you know how the things go with the pediatricians. Hopefully, they're going to be wearing a lot of unicorn headbands. I love seeing that. It's one of my favorite things. That's when I know how I know an audience is going to be really fun and engaging and they're going to laugh at my jokes, even if I'm giving a talk at like 9 o'clock in the morning, is how many unicorn headbands are in the crowd. Pediatricians always bring it. They bring it. They love it. They have a good time. So this will be interesting. To see kind of what the mood is, the tone is. I think it's still going to be pretty excited because they're all together and I guarantee you every pediatrician is feeling this. And they're all motivated to accomplish the same goals, and it's take care of kids, right? And the way to do that is by supporting vaccination and pain control in poor, pregnant people. Like, that's another thing. It's like people talking about, oh, this is an attack on women. And yeah, it really is. Like the fact the president said, gut it out. You can do it. Oh man, that's a bad look. That's not good. What if I had said that to my wife, what would have happened? I might not be here because she might not have saved me from my cardiac arrest. I honestly don't know. No, she probably would have, but she would have been more unhappy about it probably. Okay. So, all right, that's it. That's it. I'm sorry. I know like some people are going to listen to that and maybe not, maybe just skip right over it. Or not want to hear me quote, talk about politics. I get that every now and then, but I honestly don't really feel like this is politics. Like if honestly, if there was a Democrat who was doing all the same stuff, I'd be just as against that. It's about science. It's about evidence. It's about the practice of medicine. I align with each party on different things in healthcare. But I do lean more left, and part of it, I mean, a lot of this stuff we're talking about, So I try not to get too into politics and just keep it on the medicine, the eyeball stuff. But sometimes you can't help it because there's so much intertwined uh, uh, between politics and medicine sometimes. So anyway. All right. So anyway, we'll timestamp it. Welcome back, everybody who didn't want to hear me talk about politicians. Let's talk about eyeballs. All right. So I got today a discussion about. Actually, before we jump into that, I'm going to do a couple of questions, a couple of the comments from the most recent episode. Oh, this was a good one. At Biostat196 said, "Hey, Dr. G. I'm a PhD student in biostatistics. My professor mentioned that in nearly every specialty, they call a study either single or double blinded. But guess which specialty uses a different term? Ophthalmology. Apparently, in ophthalmology, they call it masked. Masked. Actually, I've never heard that, but I think it's really kind of funny. It's like the stigma that has to do with blinding. We don't want to put it in our research. I think that's maybe overkill. I don't think you need to do that. But I have never heard that. I'm going to check in with some of my ophthalmology research colleagues, though, because, again, I don't do research. Like I've said before, looking at an Excel spreadsheet kind of makes me nauseous. That's how much. I have one publication. I think I published it in the ophthalmology journal of Siberia, or I don't even know where the hell it was published. It was not a good. Anyway, that's the extent of my research. So I'll check on that, see if it's masking instead of blinding. I would love to know if that's true. Some other great, some people say, some topic ideas. Someone asked about vision therapy. Let me think about that one. Vision therapy is kind of tricky because there's, I would say, there's no ophthalmologist that does vision therapy. I think some of the things within vision therapy have evidence behind them. A lot of it doesn't. So, and it's just not something I think about. So I need to do a little bit of work, but I'll try to include that in a future episode, just talking through vision therapy. Some good, some bad stuff in vision therapy is my personal experience in seeing people, talking to pediatric ophthalmologists, because pediatric ophthalmologists, I would say, have a little bit more overlap with people that do vision therapy because they get referrals and talk to parents who are getting second opinions, who have maybe gone through vision therapy and are now seeing an ophthalmologist, pediatric ophthalmologist. So, and I have a couple pediatric ophthalmologists in my life, so I'm going to chat with them about vision therapy and I'll get back to you guys. All right. That's a great idea for a topic though. And one that a few people have mentioned. Um, let's see here. Some of you tried the eye dominance test and got conflicting results. I talked about eye dominance, how you make a circle with your fingers and you hold it up to whatever you're looking at. And then while you're holding it right there, close one eye. And if you can see the spot you're looking at through your fingers, then that's your dominant eye. All right. If you close the other eye and you don't see it, that's your non-dominant eye. That's a kind of a rough way. The only way that I know of checking eye dominance, and again, we use that if people are getting monovision with cataract surgery, where they have one eye that's set for distance, one eye that's set for near. We want the dominant eye to be their distance eye. And so we'll do that test, which is again, if someone has a better idea of how to check eye dominance, please let me know. But that seems to work pretty well. I don't think I've mistakenly done it. And honestly, even if you get the eye dominance wrong, people can adjust pretty well to it. You have neuroadaptation that occurs that allows you to kind of figure it out. The biggest thing for people who are interested in monovision, especially when it's permanent with cataract surgery, is checking it with contacts first in a way that's not permanent. So you give them a contact to just use in one eye if they're nearsighted. So they have one eye that's distance, one eye that's near. Have them walk around for a few days. See if they like it. Some people hate it. Some people love it. There's your answer right there. If they love it, we're doing monovision cataract surgery. If they hate it, we are not doing monovision cataract surgery. All right, so let's take one more break, and then we'll come back with our ischemic optic neuropathy topic. All right, so ischemic optic neuropathy. So I'm going to do one that's actually I have seen once. So the most common form of ischemic optic neuropathy, and basically what that means is just like it sounds, you lose blood flow to the optic nerve, and part of the optic nerve kind of dies off. All right, optic nerve needs blood supply. You don't want to lose that because you'll have damage to the optic nerve, and that can give you visual field defects primarily. All right. So the most common one is what's called anterior ischemic optic neuropathy. There's different forms of that. There's non-arteritic. We're not going to be focusing on that because that's too common, right? We're going zebras here. We're going very rare things. So I'll tell you two forms of optic neuropathy. One I have seen one case of, and one I have not seen any cases of. All right. The first is called posterior ischemic optic neuropathy. So when people get this, the symptoms of an ischemic optic neuropathy are painless vision loss. As opposed to anterior ischemic optic neuropathy, which can occur with you sitting on your couch, especially if you are older, in your, I'd say, 60s and up, or maybe a little younger than that. But you can just be sitting on your couch. Usually you have some kind of vascular disease, either diabetes, high blood pressure, coronary artery disease, something like that. Posterior ischemic optic neuropathy most commonly occurs in the postoperative setting. All right, and this is what happened with the case that I saw. A patient had a 12-hour spinal surgery. Now, when you're getting your spine operated on often, and I'm not a spine surgeon, but it's my understanding that people are usually they're prone in a prone position so that the surgeon has access to the spine, right? So they're face down. Well, this particular patient that I saw, this is during residency years ago. The patient was in that position for 12 consecutive. It was a long surgery. I think they had some complications, so it took a little bit longer than they expected. But during that case, the head was not positioned quite right on the headrest. Again, face down, but the headrest was actually pushing on both eyes the whole time, the whole 8 hours. And so what that's going to do, if you put pressure on the eye, it'll increase the eye pressure. Think about like kind of squeezing a balloon, right? The pressure gets really high in there, and that can decrease the perfusion pressure. It increases the perfusion pressure. And so you need a higher blood pressure to push blood into the eye to get, to keep everything nice and healthy and working. And so this poor patient had pressure on the eyeballs, which basically did not allow blood to flow into the eye, and at least in the back part of the eye. And so you ended up with a posterior ischemic optic neuropathy. It was basically the kind of the back part of the optic nerve as opposed to anterior. The back part of the optic nerve didn't receive enough blood flow because of that pressure and the prolonged nature of the surgery. There was also points of low blood pressure during the surgery, which made the problem even worse. And the patient ended up waking up after surgery with hand motion vision. 20/20 before surgery, hand motion vision after surgery. So that means all they could see is their hand moving in front of their face. Now, this sounds really scary, and it was. This patient has stuck with me for years, and it may make you think like, hey, I never want to have spinal surgery because of that. That's very scary, and I get it. But keep in mind, this is extremely rare and is a known potential complication. That the spine surgeons they're aware that this is an important thing, and anesthesiologists who position the head frequently. And so that's all it takes is just diligence to make sure that the patient that you're positioned appropriately. All right. And so it's extraordinarily rare. I think I looked at this before. It's like something like 2 or 3 cases per several million. And so it's not something that you really need to be concerned about, but we're just talking rare things today. Okay. So that was a case of posterior ischemic optic neuropathy, most common after spinal surgery or just long surgeries in general. You don't have to be face down either. That's just the time that I saw about it, and the cases I've read about it are mostly in that position. But just any long surgery where you have periods of low blood pressure, that's why maintaining a certain blood pressure during surgery is so important. Operative planning in high-risk patients should include attention to head positioning, length of surgical time, balance the risks and benefits of hypotensive anesthesia, aggressive replacement of blood loss. I'm reading off of this manual I have that talks about this disease. So it was difficult. I just remember the conversations with the family, and it's that I don't know what ended up happening in terms of any kind of legal action that was taken, but that would be a high risk one, right? It's because it's something that, unless that you're talking like life-saving surgery where you're not able to control blood pressure, like there's certain things you can do to mitigate this risk, and that's very important to consider. Okay, so let's talk about one that I have never seen before. So this is called Leber hereditary optic neuropathy. So this is a painless progressive vision loss in one eye and then the other that occurred days to months of each other. So very quickly, one after the other. The vision loss is bilateral at onset in approximately 25% of patients. So some patients get bilateral vision loss right away. Some get it one eye, then the other. So what you would find on exam, patient comes in to see, usually there's a young person. You'll see mild swelling of the optic nerve. When you look back there, dilate people, look back, see the optic nerve. So mild swelling of the optic nerve that progresses over weeks to optic atrophy. So that's what happens when you have some insult to the optic nerve. It'll get swollen, but then if you start losing blood flow, then it'll just become white. It'll become atrophic, and you'll have what's called optic nerve atrophy. And so the visual acuity devolves down to 2,200, sometimes count fingers. You can get central visual field defects. That's very common with optic neuropathies. is that you have a kind of central blind spot. And sometimes that progresses to off center a little bit. But it takes out your central vision, which is your optic nerve is very important for central vision. That's where the vast majority of your nerve fiber layer is it maintains that the center area of your vision versus the peripheral part of your vision. Now, the way this is hereditary. I mentioned LHON, Leber hereditary optic neuropathy, is transmitted by mitochondrial DNA. Mitochondrial transmission. So it's transmitted by mothers to all offspring. However, 50 to 70% of sons and 10 to 15% of daughters will manifest the disease. So it's incomplete penetrance. Just because the mother passes on her mitochondrial DNA to her offspring, that doesn't mean that offspring is going to exhibit this disease. All right. So, but the vast majority of sons do, and some of the daughters do. Now, all the daughters are carriers, right? Because mitochondrial DNA is always passed down from the mother. So the daughters are carriers. They can keep spreading this down to future generations. The sons cannot. So the disease will stop with the sons. They cannot pass it on to their offspring, but the daughters can. Now, genetic testing is available for most of these. So we can actually figure out the exact nucleotide sequence that is responsible for this. It's usually substitutions in the NADH dehydrogenase protein. I don't know a whole lot about that. Now, here's the cool part that we have in the world of genetic and inherited eye diseases. There's a ton of work being done with gene therapy. It's really cool. We've actually have for Leber's congenital amaurosis, which is a topic we can discuss in a later episode. We actually have some cases of successful gene therapy. Now, we're not talking going from no light perception to 20/20 vision, but being able to see shapes. It's happening. It is actually happening. It's so cool. And we do have some options for patients with Leber hereditary optic neuropathy as well. I don't know if it's effective, and these are more like clinical trials that are ongoing, but this is one of the diseases that is being targeted for gene therapy. So it's really cool. I've never seen this particular one. I've seen other types of inherited retinal diseases and optic nerve diseases. This is not an inherited retinal disease, it's an optic nerve disease, but I've seen a handful of these, but not this one in particular. And it's just nice to be able to, when you see patients with these types of genetic disorders, to be able to have something like, hey, look at these. This is the trial that's ongoing. I'll keep you updated. And something that one of my retina attendings always told us was that you never tell someone that there's nothing you can do. Like, that's not helpful. Yeah, there may not be an effective treatment for a certain disease, but you can always do something. You can keep them updated with any information you have. You can refer them for adaptive technology, see if that would be helpful. You can give them a second opinion if they want. There's something to do. Saying the words, "I'm sorry, there's nothing we can do to help," is not productive. It's not a good way to build a relationship with people that desperately need it. It may be small, but there's always something you can do. Offer just words of encouragement. Just offer to still see them every so often. Because sometimes that's what patients need. They just need to be able to talk to a doctor about this disease that their loved one or themselves are going through. All right. That's it. That's Knock Knock Eye for today. Thank you all for listening. I'm your host, Will Fenner, also known as Dr. Glockner-Plecken. Thanks to my producers, Aaron Cordy, Rob Goldman, and Shanti Brick. Editor and engineer, Jason Portiza. Our music is by Omer Benzvi. That's it. We'll see you next time, everyone.
Knock, knock, goodbye.
Hey, Will,
Hey, what's up?
I've been thinking the U.S. healthcare system, it needs some improvement.
Yeah, there's room for improvement. For
Yeah,
sure.
it's a confusing, scary place for everybody involved.
Absolutely.
Physicians, families, patients, everybody.
Everybody. And I've experienced it from both sides, right? I'm a physician. I've also been a patient. So I wanted to use my platform to give people practical education, really the only way that I know how, by making jokes. So Dr. Glockenflecken's really fun and super uplifting guide to American healthcare is out, and it's a free resource that includes all my videos from the 30 Days of Healthcare series, alongside deeper explanations, also reliable facts, emphasis on reliable.
Yes.
All right. Figures, numbers, insights into how each of us can fight for a more humane, better healthcare system. Also, it has jokes.
Did you mention the jokes?
I did. Jokes.
Okay.
Yes, definitely jokes.
Well, this guide is great for anyone looking to learn more about U.S. healthcare, but especially if you are experiencing it from the clinician side for the first time.
That's
We
right.
really hope you'll check it out.
Get the free guide sent straight to your inbox by signing up for our mailing list, glockenflecken.com/healthcare. Enjoy. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.